episode, we go over what physical therapists need to know about rotator cuff repair surgery with orthopedic surgeon Dr. Sean Rockett. Welcome to the Fitness Pain-Free Show, where I help physical therapists learn how to get their clients out of pain and back to training in the gym. My name is Dan Pope, and I'll be your instructor. I'm a physical therapist, coach, and fellow meathead. I love training just as much as you do and want to help you get all of your patients out of pain and back to the gym where they belong. So first and foremost, thank you so much for your support. You allow me to do what I love for a living. My name is Dan Pope. I'm a physical therapist, coach, personal trainer, and meathead. I love fitness. I love lifting weights. This is the Fitness Pain-Free Show where we help coaches and physical therapists like you get your patients out of pain and back to training. If you are watching this on YouTube, please hit that like button, comment, and subscribe to the channel. If you're listening to the podcast, please give a 5-star review. It's much appreciated. So, if you want to go that extra mile and support the channel even further, please consider subscribing to my premium membership, Fitness Pain-Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professional. So think Netflix, but for trainers and physical therapists. It's premium content from yours truly. I make all the content on there, and it's similar content to the show, but way more in depth. It's updated monthly. I've been updating this thing for the past 5 or so years, and there's a lot on there. There's 100 plus webinars, ebooks, and complete guides. You also have access to a private Facebook group to have all of your questions answered by me. You also get a chance to decide upcoming podcast topics. So if there's something you really want to learn more about, hear me go in depth about, let me know. I can do that. And you can get started for just $1 for a week-long trial. And after that, it's a recurring membership of $9.99. All right. You can cancel anytime. All right. I won't be upset if you do. And if you want to get started, all you need to do is head to fitnesspainfree.com, click on the programs link, and then click on the Fitness Pain-Free Insiders online library and get started. So first, our expert is going to be Dr. Sean Rockett. Now, I was really lucky to have Sean on the podcast because he is the head orthopedic surgeon for CrossFit HQ, and he's been the head surgeon for, I want to say, almost 10 years now. I think 2012 is when he was first appointed to that position. He's been rated as one of Boston's top docs several years. He actually trains CrossFit, so he goes to a CrossFit gym and trains there. He's been doing that for years, and he's a proponent of CrossFit, which I think is great. You don't find too many surgeons out there that really like CrossFit. If they do like CrossFit, oftentimes it's because it drives revenue, is what they'll say, right? Because CrossFit hurts people, right? Kidding. I've been collaborating for years with Dr. Rockett. We've kind of been sharing patients. I love bouncing ideas off of him, seeing what the surgery was like. He's always very responsive. I get to text him, email him, just a good guy in general, right? He is my trusted local surgeon. So if I have a CrossFitter that has a problem that I think that may require some surgery, he's going to be one of the first guys on my list, right? So that's awesome. The other piece is he has a great website that has a lot of great information there. 321gomd.com. Make sure you check it out. And without further ado, let's get this thing going. Dr. Rockett, thank you for joining us. How are you doing tonight?
I'm doing well.
As you can tell, we haven't changed our clothes in 3 weeks now. So smelling pretty good over there, Dr. Rockett. Yeah. We batch film these, obviously. I have a really nice question for you tonight, Dr. Rockett. You ready?
Right.
Okay. What do physical therapists need to know about rotator cuff repair from a shoulder surgeon? You ready to delve into this?
That's a big question.
I know. All right. So in terms of common rotator cuff tears, it seems like the supra/infra are the most common ones. Does that mirror what you see from a fitness perspective? Do you see fitness people getting the same types of rotator cuff tears?
Yeah, I would say that it's similar issues.
Okay.
Similar tendons. Yeah. Supraspinatus, number one, probably, most infras are not isolated. Most infras are starting at the supra going to infra. So it's a progression of the supraspinatus.
Makes sense.
I probably could count on a handful how many times I've seen just an infraspinatus. Yeah.
Okay. So very uncommon just for infra.
Yeah.
Usually supra turns into infra, just kind of keeps on tearing down the line.
Yeah.
Okay,
Yeah.
very good. So here's a question that's challenging. Does cuff tear size matter in terms of how fast we progress physical therapy? So I'm talking about range of motion, strength, that type of thing.
Yeah. Just based on the science that what we're trying to prevent are failures, obviously. We're trying to hold people back more than what is probably necessary, but we're basing it on the percentages of failures of multi-tendon surgeries.
Mm-hmm.
So the bigger the tear, the higher the failure rate.
Mm-hmm.
And so we're trying to guard against those numbers. We're hedging our bets. So if we have a 3 tendon repair, we're trying to hold people back more than if it's just the supra, repair.
That makes sense. And I've heard this from a few different places. I don't know how true it is, but if we have a really big tear and our concern is failure, is it wise to do a little bit more conservative care to let that scar down better? So delaying range of motion, delaying strengthening to allow this to scar so we have a better attachment.
Yeah, I think with any repair, I think it's bad if you get stiff, because then it becomes very difficult to progress well, because then, and I've gone in on a bunch of people who have scarred down after a rotator cuff and they get bursal adhesions and they get, intra-articular adhesions or frozen shoulder.
Mm-hmm.
So I think of any surgery, we're trying to avoid that. But I think what it comes down to is delaying strengthening, definitely. So if I sort of break up my repairs into, small supraspinatuses, routine slam dunks, and then things I'm worried about: soft bone, multiple anchors, many tendons, things that have a tendency to have a worse outcome.
Mm-hmm.
So I will prolong the active motion for the multi-tendon people to be 10 to 12 weeks for active motion.
Okay.
Whereas a supraspinatus, I'm okay at 6 to 8 weeks.
Okay. Excellent. So we need that range of motion. That's key.
So
We can definitely have problems.
with range of motion, and some people, it's funny, you do the same surgery on people, and some people just don't let therapists move their arms. Some people, just get stiff right away. They get tight right away, and those are the ones you wish you had them moving a little earlier. But I'm okay with passive motion right away. Gentle motion, getting up to 90, getting out to 90.
Mm-hmm.
On mostly anybody. With a small supra, I usually start at about 2 weeks when I'm not worried about the incision, when I'm not worried about any infection, and we see them in our office at a week, give them a prescription, and then they go can set up therapy. So hopefully within 2 weeks they're starting moving.
Okay. Is that even more important for an open procedure versus an arthroscopic? Are you more fearful of?
Yeah, I haven't. I mean, it's been a while since I've done open. I'm old in the rotator cuff repair world of being 50, and so I used to do mini opens and have progressed to arthroscopic for pretty much everything. So it's been a while for open. I think it just comes down to delaying the real end range of motion with multi-tendon ligaments. If you have that infraspinatus in the back and you're internally rotating and bringing them forward, that's going to put a lot of stress on the infra. So just protecting ranges of motion when we're into infra and teres in the back.
Okay. So we need the range of motion, but we do have to be careful about protecting the tendon, depending on what tendon, I guess, they had repaired with certain ranges, I guess.
And the failures are you have the sutures coming up through the tendon, and then we're tying down the sutures. The failures are that the fact that the tendon will rip away from the suture. Mm-hmm. It's the anchors are usually fine. It's not the anchor. It's not the knots. It's the fact that the tissue quality can be poor in some people, and that they will pull through the knots.
Okay. That's another good question that I have for you. And I know I've asked this a few times with some of the patients that I've worked with together with you. Mm-hmm. Does tissue quality matter?
Absolutely.
In progression? Go ahead.
No doubt. I can go in there and see somebody and shave and check out, probe or debride their tissue. And if their tissue is avascular and not mobile, then yeah, they could have a bad outcome just based on what their rotator cuff looks like. Again, that's what we're talking about, a chronic tear. That's what we're trying to avoid, this bad, poor tissue, trying to reattach poor tissue. So absolutely, if you get a fresh tear and there's bleeding edges of that tendon and you see vascularity and you see tissue, it's going to be good. But if you go in there and you see white, smooth, shiny, white tissue paper, shriveled tendon, your stomach turns a little bit.
Yeah, so it's not going to be a good day. All right, so kind of same idea. Make sure you get the range of motion, but delay some of the strength if there's poor tissue quality.
Poor tissue quality or multiple tendon involvement, yeah.
Okay. Here's another question for you, and I got to admit I'm not really on top of this stuff, but does surgical technique matter in terms of long-term outcomes, obviously, but in terms of what I need to do as a physical therapist because there was one procedure versus another?
You mean as far as single row, double row? Is that what you're getting into?
Yeah. Mm-hmm.
Yeah. No, I think we're looking at the literature. No clinical difference between single row, double row. Double row has some biomechanical studies suggesting decreased rip-out strength, but then there's there's theories about putting too much tension on the repair. That if you pinch down the tissue with a double row, you're putting too much tension on the repair, and you can lead to a vascularity of the tendon. And then also just putting in too many sutures, getting too much suture in there, and not leaving enough space for the body to grow. And so if you you can put a ton of sutures there, but the body still needs to grow together. So
yeah.
So I'd say technique is surgeon dependent, and hopefully people are doing the right thing and doing a good job with it and getting. But as far as double row versus single row, it would be the same treatment.
Okay, so no difference there.
Same rehab, yeah.
Okay, excellent. All right. The next question I have for you is that how should rehab change based on the tendon that's repaired? Obviously, you had said there's more supra into infra, but how about if the subscap is involved versus just the traditional supra infra, and does that change?
Yeah. So if subscap's involved, we're putting tension, we're pulling here. So I'm gonna resist external rotation for 6 weeks beyond neutral or 20. I'm gonna protect that. I'm gonna protect abducting way up. So I'm for your readers or your listeners on the podcast, I'm abducting my arm. I'm bringing my arm way up. So for a supra is under tension with a ton of abduction. So I'm going to delay that. Whereas that was a subscap. So for supra, I'm okay getting it up and getting it up higher, and with some rotation, and obviously just avoiding way back internal rotation. That's going to put tension on the supra, and then with infra, just being careful, pulling across body, and so I'd say that's the big difference with subscap for me.
Okay, very good. So basically, depending on the tendon that you repair, you're restricting range of motion earlier on. The one thing that I tend to think about as well when I'm rehabbing these tendons, let's say that you have more of a supra/infra, from a loading perspective, I tend to delay loading those tendons a little bit longer. And then from an exercise perspective, usually the top and back of the cuff, so that supra and infra are more active with pressing exercises, so overhead press and like a horizontal press. So I tend to delay those a bit longer than I do, let's say, a rowing exercise, just because I know that we're probably putting more stress on those tendons. Do you kind of agree with that idea? Do you think that you have to dose the strength based on the type of tear? What are your thoughts there?
Yeah, that's an interesting point. I think there's co-contractions that take place. I think, that it's not, I don't think you can isolate, strictly one exercise is not going to do the supra. If you're rowing, is the supra going to be involved? I am a firm believer in once we, going slow early, getting full range of motion, absolute full range of motion, going slow with resistance, and then once we get to 2 months, 3 months, we're good. Like if I can get through 2 to 3 months without the patient coming in, having a clicking, having a grinding, having a catching, and pain, hopefully the pain is diminishing. It takes 3 months for that tendon to grow to bone and be fairly solid. And that's the science behind it. No one's going to speed that up. But once we can get through 2 or 3 months without anything bad happening, any new therapy kind of things going on, I'm okay.
Yeah.
And yeah, I don't mind going slow early on and going through gentle range of motion, but and it's, I hate if they're frozen and I hate if they're ripped. It's like where we got to find somewhere in between, and that's the skill of a good therapist, is when they know when can someone be pushed a little bit, what body part or what thing was repaired, and what can I move safely and what can I move not safely, and that's the tough part. That's the tricky part.
Okay. Yeah. So I guess the big thing is that we're trying to protect this from a strength perspective until we're getting to that 3-month mark where we now have a secure attachment and we can start to ramp up
some. On the fire hose. Yeah.
Okay. Excellent.
Once we get to 3 months, let's go.
Excellent. And then, I think I have time for one more question here for you.
Back to the other one. Obviously, I'd rather have a stiff, tight shoulder. So I'd rather be more cautious and go for stretching than an aggressive range of motion that's ripped. So that's, if somebody comes back stiff, I'm okay with it. But if somebody comes back ripped, that's,
not great.
Rather not.
And that actually sounds good to me, because I see a tremendous variation in how fast cuff patients get the range of motion back. Yeah. I'll see someone who has their cuff repaired and their range of motion, it seems like they almost didn't have a surgery. And then I'll get someone else that's incredibly, incredibly stiff that had what seems like a similar procedure, Yeah,
no, it's weird. You do the same procedure and, same therapist, and it's just patient type, whether they have their fibroblasts are more active and more hyper than somebody else's fibroblasts, and they're scarring quicker. And yeah, it's weird.
Yeah,
I agree. There's some people who at 2 weeks, they're like, oh, look what I can do. And I'm like, oh, shit.
Yeah.
But they turn out fine. They turn out great. So
that's funny.
It's weird.
So the last one is concomitant pathology. Basically, if someone has another procedure with their cuff repair, so like a tenodesis, lap, Mumford, how does this affect the rehab?
Tenodesis, it's pretty much the same, I would say. Just the thing I would avoid would be like a straight armed movement. I'd probably keep the elbow. It happens when I do a capsular release for a frozen shoulder and a biceps tenodesis at the same time. Like, I don't want them to be pulling, on the biceps repair. So I usually have people do a flexed elbow, forward flexion and abduction to release some of the pressure on the biceps. But yeah, if somebody has a biceps tenodesis along with a rotator cuff repair, it's, I would say, pretty similar as far as protection and, obviously no biceps curl resistance. And if you talk to surgeons, some people let them fly and let them go and let them go do resistance early. Just makes sense to me why we don't push the envelope, give them 6 weeks of scarring and then you can, start to strengthen the biceps. So, but I know some surgeons will say, oh, I'll let them flex and let them move, or not move, but let them do resistance even before 6 weeks. So, but I usually think, if we're going through the whole surgery, you might as well protect it for 6 weeks and then start resistance on the biceps if you're doing a tenodesis. Yeah.
Sure.
For distal clavicle, no, I would say no difference. Slap repair, similar to
tenodesis. Okay. And imagine if you have some labral pathology. So if it's anterior, maybe you're restricting range of motion, like external rotation, horizontal abduction, posterior, maybe the opposite, internal rotation, adduction type things.
Yeah. Straight Bankart, obviously I usually say I want to see this by about 10 weeks, get there however you want to get there, but by 10 weeks, I want you here. Obviously, and I think just people can't get to that point really even before 4 to 6 weeks. I think it just hurts too much.
Yeah. Sometimes the pain is good, huh?
Yeah, no, there's some nerve endings are good sometimes. Yeah.
Yeah, good. Okay, that's all the questions I have here, Dr. Rockett. I really appreciate your time.
Yeah, no problem. It was good. It's good.
Yeah. Hope to have you back sometime.
Let's do it.
Okay. And that's it, guys. Thank you so much for joining us. Here's what I want you to do next. If you want to learn more about how to get your patients out of pain and back in the gym where they belong, I'm going to show you exactly how to do this. I've created an entire mini course on this. It's completely free. I have the link in the bio/show notes, so go ahead and click that link and get started. Thanks again, guys.